So we're going to turn now to hormone receptor positive metastatic breast cancer and really start with, I think, data that's being presented at ESMO and go from there. Michael, the FALCON trial is being presented actually today at ESMO. Can you kind of start with that and explain that to us?
Yeah, thank you, Adam. I mean, the world is moving really quickly because actually I'm being part of the National Guideline Commission in Germany. We just finished, like 6 months ago, the update in which still, for the moment, first-line treatment in patients with metastatic hormone receptor positive disease is an aromatase inhibitor. FALCON trial is going to give us a new answer how to treat these patients, because the comparison was in this prospectively randomized trial to compare fulvestrant with an aromatase inhibitor, and to make a long story short, fulvestrant is superior in terms of time to progression to the standard of therapy at the moment, aromatase inhibitor. So I think in this round here, we have to answer some questions, because probably that will be the new standard of care for first-line metastatic hormone receptor positive patients, or those patients, and I was talking to Ahmad before, because the trial is so new. I think there were like 100 patients, 114 patients on the trial who had already a previous endocrine treatment, but had a, you are shaking your head. So the data are so fresh that probably we...
FALCON allowed no prior endocrine therapy in any setting. No, in any setting. Okay. They couldn't have endocrine therapy in the adjuvant or metastatic
Excuse
setting.
me, for adjuvant, correct.
There
for
were
adjuvant
some patients who had previous chemotherapy in the adjuvant setting, but no endocrine therapy.
So these are fresh endocrine. Now, how does that compare to FIRST, where there was a survival benefit? So
FIRST, remember, FIRST only had a primary endpoint of the benefit, clinical benefit, right?
Right.
And so the endpoints of survival were something that were added on later. Those patients also were not supposed to have had any endocrine therapy in the metastatic setting. FALCON is a more controlled group with the prospectively defined primary endpoint, so it kind of takes over the
But how
first
many
data.
people really fit FALCON? How many patients fit
Well,
FALCON?
if you
no
look,
endocrine therapy ever? That's de novo.
If you look
basically
at the
disease.
fulvestrant and anastrozole study, in the U.S. SWOG trial of fulvestrant and anastrozole versus anastrozole, 40-some% of patients had de novo metastatic disease. In Paloma 1, it was a little more than 40%. In Paloma 2, it's about 40%. In the Mona Lisa trial, it's 30-some-odd%. So we definitely are seeing these patients.
Really? It just doesn't seem to be my clinical experience.
No, me neither. But the trials are.
Okay, Adam, that was the reason right before I asked Ahmad, where are these patients? How often are we seeing them? Because I face the other problem. I see patients under current endocrine therapy, like year 4, or a aromatase inhibitor, and they develop coughing, pleural effusion, metastatic breast cancer. Now, those patients would not fit into this trial here because they are, per definition, endocrine resistant.
Right. So how do we treat those patients
So
then?
do you think, let me just ask you about FALCON again, though.
I know that this is very contradictory.
We're going to get to, we're going to talk about that.
You said that FALCON would then result in a change of the standard of care, which is interesting to me, because the FALCON data showed an improvement in PFS in the population as a whole that was modest.
Okay.
The big improvement was in patients who had bone and soft tissue disease, so node and bone, where the improvement was quite significant. But if you compare that data to what's seen in the Paloma 2 and Mona Lisa trials, that was all comers, where in both trials, almost half of the patients or more than 50%, I think, in both trials, had visceral disease. So you're looking at adding on a CDK4/6 inhibitor to an AI that really increases the PFS in patients who have our worst disease prognostically, and then you're comparing that to a subgroup of patients who have bone and soft tissue disease where we know they do well. So maybe what we're really understanding is that in those patients who have very endocrine sensitive disease, fulvestrant may be superior to an AI, and that's what it appears to be from FALCON.
Okay.
But in the population of patients, these patients who are relapsing or patients who have visceral dominant, or not even dominant, just visceral disease, that those patients probably don't have that
Okay.
difference.
So
we have to repeat, because that was kind of a provoking
it is a
statement
provoking
from me.
statement, which is good. It's very provocative. No, that's the way it should be.
Provocative, yeah. So in endocrine, I try to make a consensus here, the Copenhagen consensus.
Go ahead.
So in endocrine sensitive metastatic disease, Hope, this data are convincing enough to replace the aromatase inhibitor by fulvestrant, yes or no?
So for me, I think it's all, I mean, yes, fulvestrant is a good option. Okay. Do we know what the sequencing has? We don't know.
We don't
need
know,
a
yeah.
little bit longer term data from this trial. If they showed a survival benefit, it would be huge. I think that it's a good option.
Okay.
And in a certain segment of patients who've never had any prior endocrine therapy and have bone and soft tissue disease, it appears to improve progression-free survival. But it does involve coming in every month for an injection.
Okay.
A pill you can take anywhere. An injection you got to come into the clinic for. So you have to balance every decision against that benefit. Now, I have to say fulvestrant is going to not cause the joint pains and some of the other sexual side effects seen with AI. So there may be some additional benefits that make it even more appealing for patients who have this subset of bone only or bone and soft tissue dominant disease. So I think saying standard of care is a little bit too much.
So let me ask a question.